And we'll get started. So welcome everyone to our four-part diabetes webinar series hosted by the Office of Lifelong Learning and the Physician Learning Program. My name is Rose Young. I am the Medical Director at the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. The Office of Lifelong Learning is committed to providing reliable advice and resources for healthcare providers, scientists, and everybody committed to addressing the challenges related to diabetes. So I would like to acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So tonight, I'm very pleased to introduce Dr. Michael Yan, who will provide an overview of screening of diabetic foot complications, as well as initial management of foot ulcers and an approach to strategies for prevention of foot ulcers. Dr. Yan is an associate clinical professor and faculty advisor in the Department of Family Medicine here at the U of A. He's also a clinical preceptor at the Grey Nuns Family Medicine Center and also runs the Leg Ulcer Clinic at the Royal Alex Hospital. Outside of medicine, Dr. Yan is a wine educator and recently completed the WSET Level 4 Diploma in Wines. He is the founder and coordinator of the Noble Rot Society, a local wine tasting group for physicians, now in its 14th season. That sounds very exciting. Imagine you could give a talk on that too. He also recently started a private wine tasting and education service called If Grapes Could Talk. But tonight, Dr. Yan, very excited to hear about what you have to say about diabetic foot complications, and the floor is yours.
Okay, thank you, Rose. I didn't realize that bio is a little dated. We just started season 16 of the Noble Rot Society on the weekend. And I would be happy to give an entire talk about wine, but I'm not sure how that fits into the curriculum for your, for your program. So let me just go ahead and share my slides. Okay, so hopefully everybody can see that. So tonight, I have no conflicts of interest to disclose at all. And tonight I'll be going over an approach to screening for foot complications in our patients with diabetes. And I'll be reviewing and navigating you through the EHS diabetes foot care clinical pathway, and highlighting some of the resources and features in that pathway as a means to protect people from diabetic foot complications. A lot of that has to do with footwear and accommodative orthotic devices, etc. So we'll be talking about that. And then I've given this talk in the past where I get comments afterwards in the feedback that while the screening and prevention piece is important, people really wish that I would get into a little bit of wound care. And of course, we're tight on time, so I'll try my best to give an overview of an initial management in case patients present to your office already having a foot wound. So I'll start off with a few pictures just to get us all in the zone for diabetic foot discussion. Every April, I have the pleasure of giving a lecture to the U of A second year medical students on the diabetic foot exam. And I co-present with Dr. Laurie Murray from the Division of Endocrinology. And Dr. Murray always starts her component of the talk by holding up a plastic model of a foot for everybody to see. And she asks the class, what's wrong with this foot? And of course, there's nothing wrong with the foot. It's a perfectly normal looking foot model. But the correct answer is that it's not attached to a body. It's a joke, but it brings home the point that what we're talking about tonight really is prevention of amputation. So in this photo, just to reassure everybody, I tried to have just enough of this person's right foot showing to reassure everybody that they have both of their legs. But this picture highlights a couple of points. One is that patients with diabetes don't come into the office just with the diabetic foot issue. They have many other things as well. So the comorbidity we see here is chronic venous insufficiency. So you can see by the hemosiderin staining on the leg. that this person also has chronic edema. And that can also cause wounds, and that's a subject for a whole other talk. As far as diabetes complications, if we look closer at the same individual's foot, you'll see that there is evidence of pressure along the fourth and fifth toes. And this suggests that the footwear is not fitting appropriately and not accommodating the width of the foot. And so that's a source of pressure that can potentially lead to wounds. Here's another individual where a couple of things are illustrated here. One is abnormal nails, which can lead to problems with foot injury and infection. But also this ridge that you see along the front of the foot, that comes from the seam inside this person's sock. And there are little things like that you don't necessarily think would cause problems, but in a person with neuropathy, if they can't feel that the sock is too tight, then it can lead to problems. Here's a foot that doesn't look all that abnormal at first glance, other than dryness. And of course, here in Edmonton, everybody has dry skin in the winter. But as part of the foot exam, it's important to look between the toes. And although the rest of the foot is dry, the space in between the toes does show some signs of maceration, moisture, and this can lead to infection and wounds. We see all kinds of different foot deformities that are caused primarily by neuropathy. So claw toes and hammer toes are commonly seen among our patients. And this is due to the motor component of the neuropathy that these patients have. The increased height of the toe creates a problem in that the shoe may not have enough room in the toe box to accommodate the toe. And that results in friction and pressure across the top of the PIP joint. And you end up with calluses, as are seen in this photo here. And those can break down into ulcers underneath the callus. Additionally, there are pressure points at the tips of the toes when people are walking. And because of the collapse of the metatarsal arch across the front of the foot, the metatarsal heads are exposed. And you can end up with ulcerations of the metatarsal head. And in fact, the third metatarsal head is statistically the most common place a person would encounter a pressure callus that can lead to a pressure ulcer. The Charcot foot is kind of an extreme version of this type of deformity. In a person with neuropathy, they can sustain a small fracture in one of the bones of the foot. And this leads to a cascade of inflammatory response, including hypervascularity and bone resorption that leads to further bony deformity and structural collapse. So the normal foot architecture is lost, and you end up with a collapsed bridge, so to speak. This is not how all Charcot feet look. At initial presentation, it can be quite subtle, just one little fracture, but the foot will be warm, hot, tender, and sore. And that's our opportunity as primary care clinicians to intervene and help the patient to offload the foot, take weight off of it for months at a time. And eventually the inflammation does settle down, and you can prevent them from having a complete loss of the foot structure. Just fun fact, Dr. Charcot, who initially described what would later be known as a Charcot foot, practiced in France in the mid to late 1800s as a neuropathologist. He has a number of different conditions named after him. But the fun fact is that in his time, it wasn't diabetes that was the main cause of neuropathy leading to the Charcot foot, but rather syphilis. So in our modern day, we have an opportunity to intervene and prevent injury to patients with diabetic foot changes, but we often miss those opportunities. And so the evidence would suggest that about half of the time, we miss opportunities during routine visits to examine people's feet. Studies show that patients also miss a lot of opportunities to look after their own feet. So about 38% of people said that they check their feet, or a family member helped them to check their feet on a daily basis. But about a third of people were honest enough to admit that they never ever check their own feet. The vast majority of lower leg amputations in diabetic patients are preceded by a foot ulcer, and foot wounds are really quite preventable. And so it's definitely worthwhile and cost effective to prevent amputations, because the financial cost of the system, but also the cost to the patient in terms of lost livelihood and quality of life is immeasurable. There are many risk factors for why a person with diabetes would have foot problems. A lot of it hinges on neuropathy. And again, there are three components to neuropathy, not just the loss of sensation, but also motor neuropathy and autonomic neuropathy that leads to dry skin. Otherwise, the glycemic control and microvascular complications, as well as limited joint mobility, can also compound these risks. When we're talking about joint mobility, often we're talking about movement at the first MTP joint and the ability of the great toe to dorsiflex. And we'll talk about that a little bit later on and why that's important. So neuropathy is the most important element of those risk factors. A number of things other than diabetes can lead to peripheral neuropathy, various toxins such as alcohol. So people who are drinking heavily over many years can develop peripheral neuropathy. Pharmaceutical agents, including chemotherapy agents, can lead to permanent loss of sensation as well, and infections and injury, and vitamin B12 deficiency. The screening examination of the foot consists of 6 categories, looking at the skin, the nails, looking at structural abnormalities, as we've seen earlier in the talk. Testing for sensation using a 10-gram monofilament is a vital part of the exam. Vascular testing for most of us entails feeling for pulses at the dorsalis pedis and the posterior tibial, and checking for other signs of adequate perfusion, such as capillary refill and hair growth and temperature. And then looking at the footwear is an important part of that screening exam as well. So hopefully everybody has a 10-gram filament or know how to get one. You can order them from Wounds Canada, previously known as the Canadian Association for Wound Care. Very simple to use. It's the only tool you really need to conduct a foot exam. The use of the instrument is very simple. The only trick to remember is to approach the skin perpendicularly and press and release over a period of about 1 second, as opposed to a stabbing motion or glancing off of the skin, because that produces a different sensation. You'll see here that the black dots indicate the locations for applying the test. The old way of screening involved a 10-point system of screening. And I'll show you a screening tool later on that simplifies it down to just 5 points. The vascular assessment, again, in the office usually just entails physical exam, but sometimes we'll send people off to have ankle brachial index done, or you might do that yourself in your own office, just using a handheld Doppler. There's also something called a toe pressure, which is like an ABI, except it uses a tiny little blood pressure cuff that goes over the great toe, and an infrared detector that's taped onto the end of the toe to pick up the waveform of the pulse. And so just like an ABI is the pressure at the ankle, systolic pressure at the ankle divided by the systolic pressure at the brachial artery, the toe pressure also gives us a TBI, which is a toe brachial index, the pressure of the great toe divided by the brachial artery. You'll see different normal ranges depending on the guideline you look at. And in fact, I'll show slightly different numbers later as part of our pathway. But in a wound clinic, we would use these numbers to help to determine whether a wound is healable or not. And if it's below a certain cutoff, we would question the ability of the wound to heal. The footwear examination is part of that screening exam. So it's important to take a look at the person's shoes and also if they have any insoles. I like this picture because this is when I was with the Edmonton Southside PCN high-risk foot protection clinic. And we took this person's insole out. And there's a couple of issues with it. One, it's made of a material that's too hard for a person that has loss of protective sensation. It's not a full length orthotic. It doesn't run the full length of the shoe. And he also For those of you who are really astute, you will have noticed that it's a right orthotic that was in his left shoe. So it's important to look at footwear. So it's helpful to bring all of these elements of the screening exam together into a tool where you can put together all the observations, and then even more useful to be able to use these observations to stratify a person's risk into high, or sort of low, moderate, high, and urgent risk. And that's why the diabetes foot care clinical pathway was developed by the AHS DON SCN. And I'll show you a little bit of this pathway, but the basic idea is that it starts off with the screening exam, and the results of that screening exam then stratify people into different risk categories that inform where to refer the patient next for further assessment and for further care, and what time frame to refer them in. So maybe at this point, I'll stop sharing here and switch over to, it's okay, everybody, just switch over to the website. So hopefully everybody can see this. So this is the website of the Diabetes Foot Care clinical pathway. I was part of the working group and the steering committee for the development of this pathway a few years back. And they've done a really good job of bringing it together on this website, along with some very useful resources. So one of the things that I'll show you is this guy here, the Diabetes Foot Care Clinical Pathway Health Care Providers Guide. Okay, so hopefully everybody can see this. It's fairly lengthy document that I'll just speed through, but you can look at it in your own time. First thing to show you is the screening tool itself. And it's nice because those 6 categories of the screening exam are included here. And when you identify, for example, the fact that a person has absent sensation at one of the 5 screening sites with the monofilament, it puts them into a moderate risk category. So it's just a nice way of organizing your observations and quickly placing a person into a risk category. As mentioned earlier, the AHS screening tool calls for screening with the monofilament at just 5 sites. So the big toe, the first, third, and fifth metatarsal heads, and then just 1 spot on the dorsum of the great toe, just to make it a little bit easier and faster. So for those people who are carrying out this screen who maybe aren't as familiar with some of the findings, this instrument gives people some pictures and descriptions to help identify the different findings, like cracks and fissures and hemorrhagic calluses, that would help them to decide what category to place people into. So that's the whole section on skin assessment, the whole section on nail assessment, structural abnormalities, and then sensation testing, a little bit more description about the filament and the rationale behind why we use 5 points instead of 10, and vascular assessment and what that entails, and then finally footwear assessment. So that's a useful guide for, say, a member of your team who is not as familiar with some of the findings. Okay, so once the screen is done, then the next step is to use the assessment triage form, which will then help to solidify which risk category the person's in, and then that informs whether they can be just reassessed in the family doctor's office in 6 months, or do they need to be referred to a high-risk foot team, or do they need to be sent urgently to emerge because they need IV antibiotics. So what is a high-risk foot team, and where do we find them? So the Pathway website also has a list of high-risk foot teams organized by zone in Alberta. Not all of the clinics, I just noticed when I'm going through this, that not all of the clinics are included on this list. So if you go further down, Under the section that says aids to daily living, recognize high-risk foot teams, you can click on that as well, and that gives another list. And there are a few additional clinics that were not included initially on the first page. There are other resources that you can give to patients. For example, if your screening tool identifies the person as a moderate risk, they can be sent home with a handout with a guide to how to care for their feet. And yeah, so that's a quick tour of the diabetes foot care clinical pathway. So I'll come back to this screen here just to check in and see if I've been speaking into the ether or everyone's actually able to hear me okay, and also if there are any questions already about the pathway or about anything I've covered so far. Just to make sure, I'll see if Rose.
Hi. So far, I'm not seeing any questions, but please feel free to put your questions in the question and answer box. And so I have a question while
Sure.
we're giving the audience a chance to reflect on this. So when somebody has an issue that's sort of semi-urgent and we send to one of these high-risk foot teams, do they all sort of have are they all operating kind of on their own sort of protocols or local sort of contexts? Or is there anything that sort of holds them together?
The answer is probably they're operating according to their own limitations of who's on their team and how well they're resourced. For example, the team that I used to lead really just had myself, a nurse practitioner, and an OT, and we only ran twice a month. And the clinic that's replaced the service that I ran now runs, I think, most days of the week, and has a nurse and a very skilled nurse, a very skilled nurse, an OT, and another nurse, and I guess I think I'm actually still on that roster as a consultant too. So every clinic probably has a slightly different makeup. But they would all offer a range of services that includes vascular assessments and authorization for people to have AEDL funding toward specialty footwear and orthotics. Also compression garments if they also have chronic knees insufficiency. They'll provide education and they'll provide follow-up. And they'll provide linkages to vendors in the community that can provide shoes and stockings, et cetera. So it probably differs a little bit by the PCN or by the clinic.
Thank you. And along those lines, we have a question. Are foot care clinics covered under the cost of Alberta Health, or are the costs covered under Alberta Health?
So they should be. So they'll either be in an HS facility or they'll be part of a primary care network. So in Edmonton, Edmonton West, Edmonton South, and I think formerly known as Edmonton Oliver PCN all have foot services. Pretty sure Edmonton North does as well. I can't speak to the other PCNs across the province, but in almost all cases, it would be covered in terms of the service that's provided. The stuff that is prescribed, like the footwear, will be variably covered depending on if you qualify for Alberta Aids to Daily Living or if you have private insurance. And same with stockings, same with fully custom shoes and things like that.
Another question is, how long is the waiting time for the referrals to these clinics?
Again, it's variable. Edmonton Southside's clinic is pretty quick, getting people in just a couple of weeks. but I can't speak to the other sites.
And a follow-up question is, what if the doc is not part of a PCN? Referrals are to private foot clinics that charge a lot of money.
Hmm. That's a tough one. I hope that most physicians, most family physicians in the province are now members of a PCN. So I don't know how to answer that because there are so many different clinics across the province, and I don't know if some of them are separate from a PCN but part of an AHS facility, in which case you wouldn't have to be attached.
So imagine on this list, there are a number of clinics that would be covered under standard Alberta Health fees, or at least the physician assessment would be. And anyone could refer there.
Right.
So we have a comment from Dr. Ballantyne. In Calgary, we use podiatric surgeons and the PLC Limb Preservation Clinic, where they all work. Yes, Alberta Health covers the consult and any care provided after the consult to patients with diabetes.
Okay, great. So hopefully access is not limited by money. I'm hoping that in most cases patients are able to access these services without financial barrier, hopefully. I'm going to come back to the talk here. Just to come back to that idea of, what can we do for people with moderate risk who don't have a wound and they don't need urgent care, but they have high pressure points on their feet that need to be offloaded. And so a lot of that can be achieved with footwear. And so it's important for the shoe to fit properly, length-wise, width-wise, and also the depth of the toe box. I stole this slide here from a talk that David Lowe did at an AHS conference back in 2017, where we launched the pathway. He's a pedorthist in Edmonton that does a lot of custom shoes and custom insoles. And I just stole this from him because it's a neat trick that you can do in the office, is just pull the insole out of the person's shoe and lay it on the ground and have them stand on it and see how well the insole fits. And ideally, you want the insole to extend well beyond their longest toe. And the idea behind lint is our friend is that if there's lint built up at the end of that insole, that means there was enough room for lint to build up inside the shoe. And if there's no lint, that means that the toe is probably butting right up against the shoe. So other tips, we don't really want people in high heels because that will put more pressure on the metatarsal heads. And we want the shoe to be properly secured either with laces or Velcro. So no slip-ons and flip-flops, etc. Here are two examples of specialty orthopedic shoes that are available with stretchy fabric on the sides and the top to accommodate people with very wide feet, secondary to bunions, for example, or very high toe heights due to claw toes. I mentioned earlier the importance of the ability of the great toe to dorsiflex, because when people walk and they push off, that dorsiflexion is really important. If they can't really move their toe, then the tip of the great toe gets ground into the floor every time they step. And in those cases, it's helpful to have a shoe with a rocker bottom to it so that as the patient steps forward, they propel by just rolling off of the front of the shoe. Socks are a good idea, just to prevent friction against the inside of the shoe, and especially socks that are well-fitting and relatively seamless. Part of the role, again, of the high-risk foot teams is to have a person on the team who's an authorizer that can fill out the AADL paperwork to authorize people for coverage towards therapeutic shoes and also custom insoles. Otherwise, these insoles cost somewhere in the range of $500 a pair. And in many cases, that cost can be largely offset or completely offset, depending on the person's financial situation. So the only pointers here is that a lot of people in town make orthotics. We just want to make sure that whoever's making them is able to either make them on site or at least service and modify them on site. We're looking for orthotics that are made of a relatively soft material that accommodates the deformity rather than try to correct the deformity. And patients do need to slowly break them in over a few weeks. Otherwise, they'll find them very painful and then discontinue their use. So, so we talked about prevention, which is really the main point of what I want to discuss tonight, and the main point behind most of the patients that you'll navigate through the clinical care pathway. But inevitably, we'll encounter people in the office who already come in with wounds on their feet. And so I wanted to just really quickly go over an approach to treating wounds. The first question is the wound healable? Will the wound be a healable wound, which is something that responds to best practice dressings and offloading devices? Will it be a maintenance wound in that it can't heal right now because of some reversible condition that the patient has, but will be healable later if that condition is corrected? Or is it just non-healable? There's really no way that this wound will recover, and we would treat this wound more palliatively. So one of the mnemonics that have been developed over the years to remember conditions that might render a wound difficult to heal or non-healable is this DEAD mnemonic, which includes drugs like immunosuppressive agents or chemotherapy agents that can slow down the healing process, uncontrolled edema, such as with chronic venous insufficiency, low protein states, so people with low albumin will have trouble healing a wound, as well as low hemoglobin. And there are various diseases such as inflammatory conditions, collagen vascular diseases, and stage renal failure that can also limit wound healing. So when a person presents with a diabetic foot ulcer, as a primary care physician, we can intervene and play a role in a number of different ways. One of the ways is to treat the underlying cause, and that might include ischemia or pressure. Another way is to provide local wound care, and then also addressing patient-centered concerns such as occupational factors and pain relief and other such things. So when it comes to treating the underlying cause, sometimes we'll see people who have diabetic foot complications, but they also have chronic venous insufficiency. And so applying compression therapy with the help of a high-risk foot team or home care would be important. And again, this is a subject for a whole other talk on venous insufficiency ulcers, which I'm happy to do at a later time. In the case of ischemia, sometimes it can be reversible with the help of our colleagues who work in interventional radiology or vascular surgery. And so, so a referral can be helpful there. And in many, many cases with our patients with diabetes, it's important to offload the foot. So an air cast or removable walker boot is an example of something that's fairly readily obtainable to help offload a pressure wound. When it comes to local wound care, there are three components that as physicians we can help with. One is debridement, another is dealing with infection and inflammation, another is moisture balance of the wound base. Debridement can come up in many forms. Autolytic debridement is just selecting a dressing that provides an environment for the body's own enzymes and macrophages to break down slough and other non-viable material in the wound. Mostly what we do in wound clinic is sharp instrument maintenance debridement. That's using scalpel, forceps, sometimes scissors to remove callus and to remove loosely adherent slough and eschar. Technology that we don't have in clinic, but we wish we had, involve various forms of high pressure water-based technology, as well as ultrasound and enzymatic debridement. And we don't have access to biotherapy, otherwise known as maggots. At least we don't readily have access to it, but in some cases, I wish we did. So debridement kind of looks like this. One of the questions that we can help to answer as the as the most responsible clinician on the team, is whether it's wise to debride or not. And so if a person falls into a non-healable category, let's say, for example, if they have ischemia that cannot be reversed, and they have a wound that's covered with a fairly dry, intact eschar, it's really much smarter to leave that eschar in place because it's providing a natural bandage and a natural barrier to infection. And opening it up just creates a wound that will never heal. Here's an example of one of my patients in my family practice that I've been seeing recently with a diabetic neuropathic wound at the tip of her D2. So on the left, that's pre-debridement, and I've just gently teased off some of the eschar and callus and trimmed some of the callus that's formed around the edge of the wound to reveal just a nice, clean, shallow 1 millimeter wound. And the orange pigment is from iodosorb, and that just happens to be the dressing that I'm applying. It's an iodine-based paste dressing. So we talked about debridement. Moisture balance is also important. One of my mentors used to say a wound should be not too wet, not too dry, just like the surface of your eye. So just the right amount of moisture to allow the body's natural enzymes and also macrophages and the cells that lay down granulation tissue and lay down epithelium to do their thing, but not so wet that you see maceration. So we saw this picture earlier. I'm just putting it back up again just to illustrate that these wounds are a little bit too wet, a little bit too exudative, and it's resulting in maceration of the skin around the wound margins. So if a wound is too wet like that, then there are a variety of different products that can be applied to the wound to absorb moisture and draw it away from the skin. Different absorbent pads and foams and hydrofibers, alginates. So in terms of selecting dressings, most of us in private practice wouldn't have a wide selection of these products in our office. So we do rely heavily upon home care. They do have an access to a very wide array of products. And thankfully in Alberta, for now anyway, the cost of all these products is covered by the government. And that's not always the case in other provinces. In many other places in Canada, people have to pay for their dressing materials. And here, it's all covered. There's a very, very good level of expertise about wound care in home care. And they have a regional wound care protocol that helps them to decide what dressings to apply depending on different conditions of moisture balance. If a wound's too dry, we can add hydrogels in the form of, say, intrasite, for example, being the most commonly recognized gel. So we talked a bit about debridement and moisture balance, and the other really important area that as physicians we can contribute is recognition of infection and inflammation and the management of those conditions. So the amount of bacterial involvement in a wound is on a continuum. All wounds are contaminated in that they all have bacteria on them, and they're typically just your normal skin flora. And then they can become colonized, but as long as they're colonized and there isn't enough bacterial growth to stimulate an inflammatory response, then the wound will probably continue to heal at a predictable rate. When the wound becomes critically colonized, that means that there's enough metabolic activity by bacteria to trigger an inflammatory response, and the wound stops healing. And then when the wound becomes frankly infected, it will actually get much, much worse rather than healing, and the patient can become quite ill. So as an example of a healthy wound, this is a wound that has very, very healthy granulation buds, very clean. You can see some very shallow new epithelium around the margins. The edges are gently sloped. Moisture balance is nice. There's no evidence of maceration. The wound is nice and shiny and moist. So granulation buds always remind me of Swedish berries. I don't know why. Sorry if I ruined Swedish berries for some people. This wound, on the other hand, is not pretty. It doesn't look like Swedish berries. There are all kinds of signs that there is at least critical colonization and probably deeper tissue infection, including erythema and drainage, discharge, warmth, swelling. Here's another example, a patient I have in my leg ulcer clinic who had an infection on a wound at the tip of the fourth toe. This is a patient with neuropathy. And something you don't see that often, but this is ascending lymphangitis. So I think I've only seen that a couple of times in clinic. The people who develop wound care guidelines here in Canada really like their mnemonics. And so they came up with this pair of mnemonics to differentiate between critical colonization on the left and a frank deeper tissue infection on the right-hand side. So the difference being that with critical colonization, the wound healing stalls, but the wound doesn't necessarily get worse, but it just shows more exudate and more red friable granulation tissue instead of the healthy granulation buds that you saw earlier. And it starts to smell and it starts to be a bit more debris and slough on the surface of the wound. For a more frankly infected wound, not only has the wound healing stopped, but the wound is getting bigger and sometimes new satellite wounds appear. Sometimes the wound will start to tunnel and form sinus tracts that can probe down to bone. It'll be very warm and it'll be swollen and red and will smell even worse. So when we're talking about infection or critical colonization, depending on how long the wound has been there, the chronicity of the wound, you would have different types of bacteria present. Younger wounds will have mostly skin flora, whereas older wounds tend to be very polymicrobial. And as you all know, diagnosing a wound infection is based on clinical grounds. The reason we swab is just to tailor the therapy. The Levine method just refers to a method of swabbing the wound after it's been cleaned and debrided, pressing with gentle pressure using the swab onto the wound base until some fluid is expressed and starts to wet the swab, and then rolling that swab across a 1 centimeter squared area. To address critical colonization, typically it's topical antimicrobials that are used. And there's a whole host of them. And again, home care has access to all of these. We have access to them in wound clinic. Physicians may choose to stock some of these in their practice if they see enough patients with diabetes and expect to see people with wounds. They may want to have some silver dressings and iodine-based dressings. Medical grade honey is an interesting one. Home care does have that, and it works quite well. And I don't know if it's something that you'd want to stock in the office, but it can be quite helpful. So interestingly, there are some topical antibacterial antimicrobials that we want to avoid because they either cause skin sensitization and dermatitis reactions, or because they harbor antimicrobial resistance that can make treatment more difficult later using a systemic agent. So a lot of over-the-counter topical antimicrobials contain neomycin or bacitracin, which are both known as potent skin sensitizers. Fusidic acid as an ointment sometimes contains lanolin, which can also trigger sensitization. And let's just go back to that. So products like mupirocin in its cream oral ointment form and also fusidic acid in its cream form typically are quite useful and less likely to trigger sensitization. If a person has a deeper infection like cellulitis or even osteomyelitis, then we will probably end up referring them on to see one of our infectious disease colleagues so that they can be seen in IB clinic. But in the meantime, if we're needing to start empiric therapy for initial management, these are just pulled straight out of Bugs and Drugs. So you can use that as a resource to determine what agents to use and for what length, and first line and also second and third lines, depending on if they have allergy to penicillins. So that was a real quick review of wound care. Like I say, I usually would do this talk purely focusing on screening and prevention, but it leaves a lot of folks with questions about how to manage a person who already has a wound. So I tried to cover as much as I could in a very short period of time about how to approach managing a wound. Hopefully that was helpful, and I'll answer any questions to the best of my ability if you have them. But in summary of what we talked about tonight, number one, remember to look at feet. Use the screening tool in the pathway to make sure that people have access to offloading devices such as shoes and insoles to protect their feet from further injury. And then if they have a wound, then refer them as appropriate to a wound clinic or to home care. But then depending on your comfort level, you can manage them initially in the clinic. And for resources, again, I highlighted the EHS Foot Care Clinical Pathway that has tons of resources that you can look at. But also Wounds Canada is a national organization that has a very informative website as well, information for clinicians as well as for patients. I hope that was helpful, and I apologize if I raced through some of the topics a little bit quickly. I wanted to make sure I got everything in within a reasonable time frame and allowed some time for questions at the end.
Thank you very much for that comprehensive review. I have a few questions here. So the first question is, where do we send our patients to get the orthotic shoes?
So just to be clear, there are a few different types of shoes that we can refer our patients to have fitted. There are off-the-shelf shoes that are commercially available that just happen to be the right size and width and length. But they're otherwise just standard runners, and those could be just all the person needs. Then there are specialty orthopedic shoes, which are a specialty item that's wider than you normally would see or has a higher toe box than you normally would see. And then there are custom full contact orthotic insoles that can go into any shoe. It can go into a standard shoe, it can go into an orthopedic shoe. And then there are fully custom shoes where the person has a mold made of their foot and then a plastic model of their foot created and then a shoe built around that. And that's a highly specialized item for a person who has such bad deformities that there is no other available shoe that accommodates their foot. So those are all the different kinds of footwear that a person could access if they were referred to a high-risk foot team. So if there's a high-risk foot team in your practice area and they accept referrals for a person with moderate or like a bad moderate diabetic foot, the team would assess these individuals and decide whether they qualify for AADL funding. They'll fill out the appropriate paperwork, and then they'll give the patient a prescription for the specialized footwear. And they will typically supply the patient with a list of vendors in the community who are able to produce these either custom products or off-the-shelf products or modified off-the-shelf products.
So it sounds like the general assessment, though, for requiring additional footwear would be recommended to refer if the particular practitioner doesn't have experience in doing that or training in that. Would you be recommending that would be the way to go?
Well, there's two parts to it. I think among family physicians and among primary care clinicians in general, there's probably a range of expertise in the kinds of shoes that are available, and also a variable degree of knowledge of the people in the community who can provide this. Some people really know this area well, and they know exactly what the patient needs and where to refer them, but they're not an AADL authorizer. So your patient who doesn't have private insurance doesn't have the $500 to get the insoles. You know exactly where to send them, but um, the appropriate step here would be to refer to one of the high-risk foot teams because they would have an authorizer on the team, and then they can fill out the appropriate paperwork so your patient can access that device.
Thanks for clarifying that.
Mm.
And I do see that on the website, on the pathway, there is the Alberta Aids to Daily Living program list of therapeutic footwear suppliers for therapeutic shoes. So that's on the website for the foot care pathway. Another question is, can you please give some specific names to the dressings that add or subtract moisture? And it may be simplified because there's also a request for your PowerPoint slides if you're willing to share those after the talk.
Um, I'm happy to share I probably shouldn't share the slides. I know the whole thing is recorded, right? So the entire
Yes.
webinar can be viewed afterwards. But I'm going to show you guys something. I thought this question might come up. So just going to show you guys. There is a tool that is available from from Wounds Canada called the Product Picker. And so this, again, still doesn't have specific brand names. And I wanted to avoid doing that tonight. I want to specifically avoid naming any specific brand names of dressings. But this at least gives a guide to the different classes of dressings and where they might be applied, where they might be the most appropriate for adding moisture or subtracting moisture. So alginates, for example, are generally used for highly exudating wounds to absorb moisture. And whereas films and membranes are for less exudating wounds, and foams can be also used for highly draining wounds. It's funny, my clinic is in a tertiary care hospital at the Royal Alex, but unfortunately, because I share outpatient department with many other specialties, my budget for dressings is very limited. And so we only have one or two examples of each class. So I know a particular brand really well because that's all we have. Home care has a much wider selection of different brands. So sometimes if you have a specific patient and you're referring them to home care for wound management, you may want to get on the phone even with the case manager just to inquire about the specific types of dressings that they would normally use according to the regional wound care protocol. And that might inform specific favorite dressings that you may want to stock in clinic, just in case somebody actually comes in with a wound that needs immediate care while they're waiting for home care to take over. I hope that's okay. I'm just being a little bit intentionally evasive because I don't want to be inadvertently advertising for any particular firm that makes these wound devices.
Thank you for the resource. So a couple questions on topicals. Which topicals should one use for the wounds? And when you mean skin sensitization using certain skin ointments, what does that sensitization entail?
So the sensitization really is a contact dermatitis. So a person has a wound, they've been maybe self-treating it for a little while at home, and they've been putting an over-the-counter broad-spectrum antimicrobial on it, and it's going fine for a little while, but then after a few weeks, because this is a non-healing wound, so a few weeks goes by, and now they have a really inflamed, very exudative wound. They may have an itchy contact dermatitis rash around it, and they're much more uncomfortable now. And so we try to avoid that by just being conscious of certain compounds within these agents that are known to be skin sensitizers, and just trying to stick with, again, typically mupirocin and fusidic acid are relatively safe to use as creams and ointments. For topical antimicrobial dressings, there are a variety of them. Some are iodine-based, some are silver-based, and they come in sheets, they come in mesh, they come in paste form. Medical honey also comes in sheets and paste. And so these are all different options. I think most people would, at this point, be looking at making a referral, again, usually to home care, and they have the full array of products that they can access, again, fully funded, cost the patient nothing. And so, so hopefully that was helpful in terms of the general types of topical antimicrobials and cautionary a word about things to avoid. I hope that was helpful.
Thank you. Just on that, actually, so when would one refer to wound care versus one of the high-risk foot teams?
So somebody asked about waiting times earlier for high-risk foot teams, and I made a comment that last time I checked in our PCN, the wait time wasn't bad. That's really more for preventative care. The wound clinics in Edmonton, I think, have a relatively long wait time. So if you have a person with a wound and you want to refer them to one of the wound clinics, so for example, the Royal Alex Diabetic Foot Clinic, or my clinic at the Alex, which is the lower leg ulcer clinic, or the wound clinic at the Misericordia, their wait times are pretty long. So in the meantime, it's a good idea to link up with home care who can see them much faster. Typically, an active diabetic wound is seen very, very quickly by home care, usually within a day or two. I hope that helps.
Oh, wow. So they could actually get a wound care nurse to assess in the meantime while they're waiting for the referral to the physician at the high risk clinics.
Most of the time, if I see a new patient in wound clinic as a new referral, they've been waiting about 6 months for their referral. In the meantime, they actually have been followed by home care. And we continue to collaborate with home care even after we were involved in clinic.
Okay, that's great to know. So you can sort of do dual referrals if you know it might be a while, or if you want some additional help with an active wound.
Yeah, home care is really valuable for that.
Okay, great tips. Another question about what is soft material for orthotics? I have seen mostly hard material. Can you comment on that, please?
Yeah, so if you remember the photo I showed with that black shiny orthotic device, that was a really, really rigid hard plastic device, and you'll often see orthotics that look like that. The other photo I showed that had more of the peach color layer and blue layer, those are more compliant kind of materials. They're a little bit softer and they provide a little bit more pressure offloading and cushioning. So most of the time, if a high-risk foot team is referring a patient to one of the orthotists for making an orthotic specifically for pressure offloading, they'll come back. I don't know what the stuff's made of, just off the top of my head, but it's a much more compliant material. When I used to do these talks in person, we would have examples of these different orthotics to pass around, but I wish I could show you. I used to call it the orthotic petting zoo. We would pass these shoes and things around. I hope that helped. I think maybe to better answer that, there are two types of orthotics. There are accommodative orthotics, which is what we use to offload pressure on a deformed foot. And then there are corrective orthotics, which we prescribe for people with fallen arches, for example, where we're providing more of a structural support for the foot. So in this context of pressure offloading to prevent ulceration, we're looking at an accommodative orthotic. And that's why the material is more soft and has more give to it.
Thank you. And maybe this can be the last question for the night. Can you please address the pain management for deep ulcers?
Ooh, boy. Okay, so
Not a straightforward one, but I thought it was an important question.
a lot of patients with diabetes, for better or worse, don't have a lot of pain because they're neuropathic. Um, they may have other forms of pain related to their neuropathy, but they don't have a lot of pain from their wound per se. Um, a lot of my other patients that I see with venous leg insufficiency, interestingly enough, a lot of their pain is neuropathic too. They don't have a neuropathy necessarily, but it's the pain around the margin of the wound is very much a burning, fiery nerve pain. So sometimes we need to address that the way we normally would with neuropathic pain. Otherwise, uh, for pain control, um, it's always tricky with pain control. If they happen to get relief with acetaminophen and other over-the-counter agents, that's great. Occasionally, I have to start some patients on opioids to get adequate pain relief so that they can still function. But yeah, so hope that was helpful. It's individualized, and um, all of you guys know how to manage pain in different contexts. And so depending on whether it's incident pain or a sharp pain or more of a neuropathic pain, that would dictate the type of analgesia to use.
Well, thank you very much, Dr. Yan. We really appreciated you coming tonight to speak about this important complication that so many of my own patients have. And we really appreciate everyone joining tonight. If you could please fill out the evaluations and let us know what you thought and also what you're interested in knowing more about. We always take that feedback very seriously and hope that we can meet your learning needs. So thank you, everyone, and please stay safe and enjoy the rest of the fall.